So thank you for staying for this very last talk. Where is the... Manuel, did you take it with you? Oh, here it is. Since it's the last talk of the day, I decided to give you the take-home message right at the beginning and then provide the evidence for this take-home message, okay? So NAFLD is a lifestyle-oriented disease. We heard about genetic, it's true. There's also genetic background, metabolic background. But still, this is mostly a lifestyle-oriented disease and mostly a lifestyle-treated disease. And the lifestyle can help in every stage of the disease, starting from steatosis to NASH to fibrosis, and even in the prevention of hepatocellular carcinoma. So if we have only steatosis, we can change the dietary composition towards a healthier diet. We can do physical activity, and it would be helpful for reduction of steatosis with or without weight reduction. If a patient has NASH, then we need to add to this dietary composition and physical activity also weight reduction, as I will show you later on. How you reach this weight reduction, which diet you choose, it doesn't really matter as long as it works. You see, you get really the take-home message. And it also helps for the reduction of fibrosis. So fibrosis is reversible by diet and by weight reduction. And a healthy diet and healthy lifestyle in general can also help in the prevention of hepatocellular carcinoma, which is one of the very important complications of NAFLD, which can even occur without the stage of cirrhosis. So there can be a direct movement from NASH to HCC, even without cirrhosis, which is something very important in these patients. So we know very well that NAFLD is strongly related with obesity, and what is interesting in this study that it shows that weight gain during childhood predicts NAFLD in adulthood. So children at the ages of 7 to 13 years old, when they gain weight, boys or girls, regardless of their initial BMI, if they gain weight during childhood, they will have a greater risk of having NAFLD in adulthood. And obesity is not only related with NAFLD, the level of obesity is related with the severity of NAFLD. So the more the patient is obese, the more likely we will find NASH, fibrosis, and advanced fibrosis. Now we discussed waist circumference today, and waist circumference is by itself an important measure of adiposity and the risk of having more advanced liver disease. So the greater the waist circumference is as a measure of visceral obesity, the greater is the severity of NAFLD, actually. And yes, weight reduction is extremely validated treatment for the treatment of NAFLD and NASH, and you can see in this recent meta-analysis a constant evidence that weight reduction leads to reduction in steatosis, ALT levels, NAFLD activity score as measured in liver biopsy. However, it is less consistent with regard to fibrosis. The pooled effect measure is not significant, but with liver stiffness, as we just heard from Manuel, which is considered a good measure, a good marker for liver fibrosis, there is a significant reduction in liver stiffness with weight reduction. Oh, sorry. No. I just want to go back. Can I go back? Which, oh, I see. You had a spoiler now, but you will excuse me. All the best slides. Okay, so, and we can learn a lot about the importance of lifestyle modification and weight reduction in the treatment of NASH by looking at randomized clinical trials, looking for medication for NAFLD, but now we just pulled out only the placebo arm. And the placebo arms is very interesting because we have long-term follow-up and we have repeated liver biopsies, which you don't usually have in clinical practice, right? So in these randomized clinical trials, when we look at the placebo arm, we can see that the placebo, 25% of them had improved NAFLD activity score, but by at least 2 points without any structured diet and without any medication. And 21% of the patients in the placebo arm improved fibrosis by at least 1 point. And that shows us the significance of just lifestyle modification happening in clinical trials just by the increased tender love and care given to these patients during a clinical trial. And this is a very nice study that Manuel conducted and shows us the very nice effect of lifestyle modification, a very comprehensive lifestyle modification on liver histology in the long-term follow-up. And here you can see the perception that we coined, Manuel and I, from this study of how much weight reduction is needed to achieve improvement in each feature of liver histology in NAFLD. So if you want to get NASH resolution in most patients, you need at least 7% weight reduction. If you want to get fibrosis regression by at least one stage, you need to get at least 10% weight reduction if you want to achieve it in most patients. If you want steatosis improvement, 5% weight reduction is sufficient. However, sadly, as you can see, only 30% of the patients during a very comprehensive lifestyle intervention achieved this weight reduction of 5% of the initial body weight. So, still we can be optimistic because, as you can see, even those who achieved very minimal weight reduction, less than 5%, had histological improvement. And those achieving between 5 to 7% weight reduction still had improved, very impressive improvement in steatosis, fibrosis, and NASH. So in some patients, even modest weight reduction can be very effective in improving even NASH and fibrosis. And this study also supports this notion, and you can see that a weight reduction even below 10% will reduce fibrosis, but still 10% weight reduction from initial body weight is the most effective one in reduction of fibrosis. So for fibrosis, we need to work harder, probably. And what I wanted you to see here is it is possible to get a regression of fibrosis even from stage 4 and 3. So it doesn't mean it's not reversible. Please remind it to the patients. And which diet is the best to get steatosis reduction? So this study is a very nice randomized clinical trial of 18 months, and they compared low-fat diet and Mediterranean low-carb diet, which is quite hard diet. This is both Mediterranean and low-carb diet, okay? It's not easy one. And they divided the arms with and without physical activity. And you can see that the weight reduction was the same for all treatments. But the best steatosis reduction occurred with a combination of both Mediterranean low-carb diet and physical activity, leading to 80% relative reduction in the amount of liver fat. So it's not only the Mediterranean low-carb diet that was better than the low-fat diet, but it's a combination with physical activity. And this is an important message for the patient. The combination with physical activity is very important. And what to do with the lean NASH patients? We heard about it a lot from Rami. And yes, we do recommend to the lean or so-called normal weight NAFLD patients to have some weight reduction, especially if they had a recent weight gain. Then they can correct this recent weight gain by some kind of a weight reduction, a modest one of about 3 to 4 kilograms, which have been shown to be effective in the reduction of the amount of steatosis. Other things we can offer to the lean patients is reduced intake of fructose and sugared soft drinks, as we heard in the previous talk, reduced intake of dietary cholesterol, which specifically was demonstrated to be related with NAFLD and NASH in the lean patients, specifically to the lean patients, and increased physical activity, which decreases the amount of visceral fat. And we heard that in the lean, so-called lean patients, there is still increased visceral adiposity as compared to lean controls. So it is still important to find ways to reduce it, and physical activity is the best way to do it. So let's talk a little bit more about dietary composition. So we know that we need to reduce the amount of calories to get weight reduction and so on, but many patients fail to get weight reduction, and so it is important also to offer them other effective options in the treatment of NAFLD. And we know now that diet quality by itself, not only through weight reduction, has a very important effect on metabolic alterations and including non-alcoholic fatty liver disease. So it's not only the caloric intake, it's the macronutrient intake, the micronutrient intake, and it's also the way that we prepare the food. And it's also the processing level of the food that have an important metabolic effect beyond the caloric intake. So the most hot topic nowadays is the issue of ultra-processed food, because we all eat that, and more, the portion of the ultra-processed food in the European diet, in the Western diet, is just growing, especially for children and adolescents. And so I would like to focus a little bit on the ultra-processed food and its metabolic effects and relevance to NAFLD. How do you recognize an ultra-processed food? Well, you don't cook it at home, and you don't have the ingredients you can find in ultra-processed food in your kitchen. For example, you don't have hydrolyzed proteins. You don't have high fructose corn syrup, right? You don't have hydrogenated oil or cosmetic additives, right? So the things you don't keep in your kitchen, you will find in the ultra-processed food, which is actually designed to be more palatable, more stimulating for excess eating, for overeating, and more aesthetic. In other words, it's just designed to encourage us to eat more and more. And recent studies, recent cohort studies consistently show that it is related, that the consumption of ultra-processed food is related with increased all-cause mortality, cancer, and cardiovascular disease risk. And this is a very nice study published recently showing people that got ultra-processed diet and as compared to unprocessed diet with similar content of macronutrients, but they had ad libitum intake during this 14 days diet, and you can see that those who received the ultra-processed food were eating more calories and gaining weight. So if we want to achieve weight reduction in both children and adults, we can start by reducing the consumption of ultra-processed food and going back to home cooking diet. Not easy one, I know, but still, we need to go back to the basic eventually and cook our own food. And one of the compounds in ultra-processed food that is considered to lead to metabolic alterations in NAFLD is the advanced glycation end-products. And advanced glycation end-products is an interaction between sugar and protein or fatty acids, which eventually creates compounds which are pro-inflammatory and also induce insulin resistance. And the more we eat sugary food, processed food, fat food, especially processed meats, then the more we eat advanced glycation end products. And we absorb them, and some of it retains in the body. And several studies show that it leads to metabolic alterations as oxidative stress, insulin resistance, type 2 diabetes, cardiovascular disease, and also liver damage. So the main source of these compounds, it is everywhere. You will find it in any food you eat. But the major sources are ultra-processed food, and especially ultra-processed meats. And so we looked into processed meat in one of our studies in the Israeli population, and we had a food questionnaires which was really analyzing in very much detail the exact meat that people eat, the level of processing, and even how they prepare it. If it's well done, very well done, and so on. And what we found is that processed red and processed meat are directly related with the presence of NAFLD measured by ultrasound and related with insulin resistance measured by HOMA. And one more interesting point is the more the meat is cooked to a level of well done and very well done, it produces higher amount of heterocyclic amines, which are considered to be pro-inflammatory compounds and pro-carcinogenic compounds. And what we have shown that the consumption of such meat cooked in so-called unhealthy methods is also related with insulin resistance in the general population and also specifically among patients with NAFLD. Let's see. Do I do anything wrong? Okay. So this is also supported by another recent study, which I was also doing with a group from the United States on the multi-ethnic cohort. And what we have found that consumption of red meat, processed meat, and even overconsumption of poultry are related with NAFLD with or without cirrhosis. We could tell which patients have NAFLD with or without cirrhosis. And not surprisingly, high amount of cholesterol intake was also associated with the presence of NAFLD with cirrhosis, and in contrast, high consumption of fibers in the diet was actually a protective factor from NAFLD. So this brings us to the compounds within meat that may explain this association. Not the only thing that in meat that can explain this association, but at least some of it. And that brings us to the issue of saturated fat. There are many studies showing clinical trials, short-term clinical trials, showing that overfeeding with saturated fat as compared to isocaloric amount of polyunsaturated fat leads to increased amount of liver fat, as you can see in these studies. And even in another study, a single oral dose of saturated fat immediately within 4 hours, postprandial 4-hour measurement, have shown a decrease in whole body hepatic and adipose tissue insulin sensitivity, an increase in the amount of hepatic triglycerides. So saturated fat has both short-term and long-term harmful hepatic effect. And this is also supported by more recent studies. This is a very cute study. They got muffins for a couple of weeks. One was with saturated fat and one was with polyunsaturated fat in isocaloric amount. And you can see that although the muffins led to a similar increase in body fat and almost similar increase in visceral fat, the increase in liver fat was significantly higher in the group receiving muffins with saturated fat. And another study also showed that overfeeding with saturated fat led to increase in the amount of liver fat even more severely than consumption of simple sugars in isocaloric amount. And an epidemiological study shows we are always concerned about the effect of dairy products, whether it's as harmful health effects. And this study shows us a very big cohort in the United States showing that if you eat high-fat dairy products, you do get increased risk, okay, of having a hepatocellular carcinoma. But if you eat low-fat dairy products, you don't get this harmful effect. And again, if you eat butter, you have increased risk of having HCC. So it's probably the amount of saturated fat that actually leads to the harmful effects of high-fat dairy products. Sugar is extremely important, as we heard today, especially fructose. And the good news that if you take obese children and you provide them with low sugar diet, within just a couple of weeks, you get a very nice reduction in the amount of liver fat and ALT levels. Sugar, fructose, has also been demonstrated, especially in children, to be related not only with steatosis, but also with 60% increased chance of having NASH in liver biopsies in almost 250 children undergoing liver biopsies. So fructose consumption is also related with NASH. We should remember it, and it's also true for children. And not surprisingly, the American Academy of Pediatrics strongly recommends to do everything possible to reduce the consumption of sugar and fructose among children. It also kills us. Soft drinks actually are related in 10 European countries. It was demonstrated that soft drink consumption on a daily basis is related with increased mortality. And there was a question before with regard to fruit and fruit juice. So fruit juice are also harmful. I will discuss fruits in a second, but fruit juice is like any other juice. It's a huge amount of sugar, rapidly absorbed, and it's also related with cardiovascular-related mortality and overall mortality. I think we got enough explanations about the fructose and how it leads to increased hepatic lipogenesis, but I also want to remind you that it has pro-inflammatory effect and pro-fibrotic effect, and it also leads to gut microbiome dysbiosis, that then again leads to increased inflammation and fibrosis. One of the pathways by which fructose leads to pro-inflammatory processes is by the induction of uric acid production. In fact, fructose is the only sugar, the only carbohydrate that increases the production of uric acid. And uric acid has pro-inflammatory and pro-fibrotic effect that was also demonstrated in several epidemiological studies. So if you see a patient with increased uric acid levels, it's one of the markers, possible markers, for potentially increased inflammatory hepatic state. Fruits are not harmful if it is consumed in a reasonable amount. This is a study in Japan, so the maximal amount was like 3 fruits per day, okay? So it's not a crazy amount, but in this reasonable amount of consumption, fruits are not related with NAFLD. What is a healthy diet? So healthy diet was just suggested at the Human Health Diet by the Eat Lancet project published this year, and they did a huge amount of analysis of all existing literature, and they found that this plate that you see in front of you is the healthiest diet for both human and environment. And they calculated by prediction models and showing that if globally we would adapt this diet, we would save 20% of the global deaths, translating to 11 million adults deaths per year globally. And what does it mean? As you can see, a lot of vegetables, fruits, very little animal protein, and even very, very little amount of red and processed meat, almost going to zero. Processed meat, almost zero. Red meat, minimal amount. And generally, more recommending plant source protein, like legumes, nuts, and less animal source protein. It's kind of going to a direction of a more light vegetarian diet. And indeed, if we improve the quality of diet in people with NAFLD, even without weight reduction, we do get decreased amount of liver fat during prospective follow-up and less incident of new cases of NAFLD. So just improving the dietary composition to a healthier diet helps even without weight reduction. And this was also true in this study for people with a genetic predisposition for NAFLD. So even those who are supposed to get NAFLD, let's say, no matter what, it's not true. If they improve their diet, even if they have genetic predisposition, they don't get NAFLD. So the genetic is not a destiny. It can be modified by lifestyle modification. And here is a study where we found that if you consume in a diet higher amount of vitamin E and vitamin C, vitamin E found mostly in healthy fat, in healthy oils, vegetable oils, nuts, and vitamin C, of course, found in fruits and vegetables. If you eat higher amount of these vitamins just from the diet, not from pills, then you get a lower chance of having NAFLD and also NASH, according to NASH markers. This is a biopredictive NASH marker, but it was not associated with reduced fibrosis, unfortunately. And so we know what we have to do, but we are very far from this. And in fact, most countries exceed the recommended amount of red meat, processed meat, sugar, and soft drinks consumption. So we know what to do, but the environment goes against us. And another thing is the socioeconomic status. The lower the socioeconomic status, or in other words, the higher is the food insecurity, the greater is the prevalence of NAFLD, the prevalence of advanced fibrosis. So we need also to take care of parts of the society which have food insecurity, because food insecurity leads to greater consumption of junk food and ultra-processed food, which we saw what is the impact of ultra-processed food on general metabolic health and specifically for NAFLD. I'm always asked about alcohol. So alcohol can be consumed, not can be consumed, but the question is not whether people can drink alcohol like 2 or 3 glasses per day, because obviously NAFLD patients cannot have this amount of alcohol. The question is whether they can have 1 glass of wine per day, for example, and there is no clear answer for that. And some studies say that 1 glass a day can be protective, but the quality of these studies is quite low. And if you look in this table at the studies that show increased risk of fibrosis or severe liver event by having 1 glass of wine or any other alcoholic beverage per day, you can see that the best studies, the prospective studies, show that even 1 glass per day can lead to increased risk of fibrosis. So generally, we need to be very careful with recommending alcoholic beverages, even moderate consumption for NASH patients. And the associations have very confusing recommendations. The EASL says only the total abstinence is mandatory in NASH cirrhosis because any amount of alcohol increases the risk of ACC. The ALT says there's no clear evidence, and only the very recent ESPEN guidelines state very clearly that alcohol should be avoided in NASH patients. Physical activity is helpful even without weight reduction. This is a very important thing to say to the patients. Which kind of physical activity? Anything they can do, aerobic, anaerobic, everything is good. The best thing is combination, of course. Whether physical activity can reduce NASH or fibrosis, we do not know because we don't have studies looking at liver histology before and after intervention with physical activity. We do have some little evidence showing that physical activity may reduce fibrosis markers, but that's all I can tell you in this point. Physical activity is also helpful in the prevention of ACC, and the more you do, the better. If you do more than 2 hours per week, then you get the highest, the maximal reduction in the risk for ACC. And here is the slides just summarizing the good and the bad for ACC prevention. So not surprisingly, Mediterranean diet, physical activity, high vegetable and fiber diet reduces the risk for ACC. Coffee, which I didn't have time to discuss, but coffee repeatedly have been shown to be associated with reduced risk for HCC, something like 3 cups a day and more. And not surprisingly, red and processed meat, high cholesterol diets, sugar, smoking, and obesity are related with increased risk for HCC. So when we treat the NAFLD patients, we not only treat NAFLD, we also need to think about prevention of hepatocellular carcinoma, cardiovascular disease, and type 2 diabetes, all relevant to these patients. How do we implement? I think we should start using more technologies, apps and technologies to implement lifestyle modification. This is a nice study demonstrating improvement in physical activity conducted by a web-based program. Patients were recommended to do physical activity. They got some group training, but afterwards they just kept by themselves just by using a web-based support, and it worked very nice in the reduction of liver enzymes, inflammatory markers, fibrosis turnover markers. So that could be a good option for the patients, especially for the young patients who are very familiar with these apps. Another example is internet-based approach of lifestyle change, which compared web-based intervention as compared to in-person intervention, and actually they got similar results in all parameters tested. So web-based approach it's not for everyone, but some patients can benefit from it. And what do we say to the patients? Well, I know it looks quite complicated. In this study, we try to predict which factors we try to create a model just saying which factors predict the best lifestyle modification in our NAFLD patients, in the NAFLD clinic that we have. And what we discovered is that the most important thing is to explain NAFLD patients that this is a reversible disease, that if you change your lifestyle, even modest changes, even 5% weight reduction, even just changing dietary composition towards a healthier one, a Mediterranean kind of dietary pattern, if you increase even just a little bit, 150 minutes per week of physical activity, moderate physical activity like walking, it will improve the liver disease. So knowing that is really, really important. It is reversible and treatable. We need to provide sufficient and clear information, and very importantly, to enhance and increase the self-efficacy of the patients, to help them believe that they can do it, to help them believe that they can do even those small changes, and these small changes are actually beneficial for NAFLD. the goals that setting should be realistic. We can't tell patients, okay, you need to reduce 10% of your initial body weight. It's very scary. They've tried it before and they failed. Or they succeeded, but then they regained the weight. So we need to set the goals with the patients. It should be negotiated with them. And we should provide regular feedback not only on weight reduction. I call it a health behavior-centered approach rather than weight reduction-centered approach. They don't get compliments only for weight reduction. They need to get compliments for every positive change. They do. They started 1 day a week to walk. Great. They reduce soft drink consumption. Great. We need to be positive about every change that they do. And the environment, as we discussed today, also goes against us. Even in countries with originally Mediterranean type of diet, there's a drift away from this diet, especially in the low socioeconomic, less educated, and younger parts of the society. So we need to fight back and to see not only how we change the behavior of a single patient, but how do we impact the policy and the environment to actually help our patients to keep up with a healthier diet or healthier lifestyle. And the ISL is very much aware of this issue, and in fact, I'm not sure if you are aware of it, but we published this year a policy statement by the ISL, which you can use in your clinic, and you can share with policymakers in your country with the recommendations how to change policy and how to manage childhood and adulthood obesity, as well as the consequences related to NAFLD. And with this note, I would like to thank you for staying.